Good afternoon, everyone.
Good afternoon, everyone. It's indeed a very great pleasure to introduce today's speaker in the distinguished lecture series of IIIT Hyderabad. The speaker is none other than Professor Alison Noble, who has many awards and honors to her credit, starting with Order of British Empire, Fellow of Royal Society, Fellow of Royal College of Engineering, and so on. She is actually the Technikos Professor of Biomedical Engineering in the Institute of Biomedical Engineering, University of Oxford. She is actually a biomedical engineer, best known for her interdisciplinary academic research, and I personally know her as the face of ultrasound science, and that's what she's going to talk about today. So which means basically she has done tremendous amount of work, which gives her that recognition globally on ultrasound images and how to use them, how to analyze them, and how to maybe even improve for the end users. Professor Noble received the Royal Society Gabor Medal for interdisciplinary research contributions in 2019, and the MICCAI, which is the well-known Society for Medical Image Computing and Computer-Assisted Interventions Society, so for an Enduring Impact Award. She co-founded a startup, which is the Intelligent Ultrasound Limited, and this was acquired by Metaphor in 2017. And now it's called the Intelligent Ultrasound Group. Professor Noble is the former president of the MICCAI Society, and recently she has been holding very key roles in the UK, including the chair of the Engineering and Physical Science Research Council, Healthcare Technologies and Strategic Advisory Team, and she's also a member of UK Research Excellence Framework 2021. She is an active fellow of the Royal Academy of Engineering and the Royal Society, and an Ellis Fellow, a fellow of the Mackay Society, and a former trustee of Institute of Engineering Technology. She received the Order of British Empire Award for services to science and engineering in 2013. So I personally want to thank Alison for agreeing to give this talk in rather short notice. It is my part, the fault. I asked her rather late. She was coming here for giving our convocation address on Saturday. So I felt we should have the privilege of listening to a technical talk as well. So I asked her maybe beginning of last week, and she readily agreed. So thank you, Alison. And I look forward to a wonderful talk because she has such rich experience spanning several continents. Thank you.
Thank you. Thank you very much for that introduction. And thank you so much for giving me the opportunity to sell ultrasound to you all, maybe. So I called it the emergence of sonography data science. And what I'm going to particularly thinking about and showing you is how within ultrasound imaging, how the way we view the data and what we can do with it has been changing. And as in all good talks, first thing I can't do it, there we go. But a couple of slides I was going to show before. I was at a meeting a while back, and I was looking back at some of my old slides, and it's amazing how fast the field of medical image analysis is changing. So back in, this was in 2020, but it was capturing some bits of information. Okay, no sound, that's not good. Let me, do I need to do this? No? Okay, I will keep speaking. Is that if you took a snapshot of what the world viewed medical image analysis, forget the technology, you would see things like the applications of health was really deemed as a very important area of artificial intelligence. If you look at the front covers of clinical journals, they were talking about robots taking over the world of medicine. You were seeing that there was a massive growth in medical image analysis, so the companies and investments were getting excited about that potential. And you were starting to see the FDA in the US approving the first device to detect the diabetic eye disease. So it was relatively a few years ago, and there are also, of course, the people who are claiming that if you look at the date, 5 years from April 2017, that doctors will be obsolete. So clearly there were those over-excited expectations. And this sort of picture was very much how the last time round, when we had our AI, people were thinking robots would take over the world, there'll be a potential, and not really knowing where it was going. If we now move to 2022, I did a similar capturing. And you can see how things have changed. The medical image analytics market is still going really, really strong. But the sorts of thing that you'll see now out in the literature is about, for example, this survey, patient trust is not a barrier to AI medical imaging adoption. Trust is key to success. Workshops looking at human-machine collaboration and teaming. You have the proposed frameworks coming out to look at artificial machine learning. Is this something I need to deal with? All right, okay, I will keep talking then. And even in the more academic field, diagnostic accuracy of deep learning was being challenged. And also thinking more about data governance, privacy and sharing, and what they call trusted research environments, which is where you do your analytics within a research environment where you can't remove the data. So these conversations really moved from maybe just hype and concerns to really starting to take a handle of some of the more practical issues of how we can get artificial intelligence solutions out into the field. What do patients think? What do clinicians think? And how do we make that happen? We need to come up with better metrics. We need to think about things like data governance. And I think it's remarkable that it's only in a space of a few years we've gone further than in the conversation that we've been before in terms of thinking that we can actually get some of these tools in clinical practice. And that really is an exciting time. So what I'm going to talk about now, just as that as a general backdrop, is to look at how ultrasound's changed. As in the introduction was said, I've primarily in my career focused on ultrasound. When I started doing this would be in the early the 1990s. Everybody thought I was crazy, like, why aren't you working on MRI and CT? But for me, I saw the potential of using ultrasound. I didn't know deep learning was going to come along and help me, which it has more recently, but I still had a belief that there's actually some really interesting problems in this space. What you've seen change is it's gone from clinical applications, those sort of steadily change, steadily expand. The most recent one is a lot of interest in lung ultrasound for obvious reasons to do with COVID. You've always had the physics driving what's going on. And then you've had in the background the miniaturization of ultrasound devices, which has nothing to do with image analysis, but it means now you have wireless probes that can go, they're cheap, they can go into different locations than ever before. So you have a different end user potentially. So it's not that you just have these probes, you have the whole range of probes now. And so some of the interest now is, what can we do? And there's been market research on this. This is quite a slide I often show, which I think is quite interesting, of how it's seen the ultrasound, who will use a handheld ultrasound, how that will change over time. And you can see it goes from basically hospital-based applications, talks about things like rural primary care, but it goes into sports medicine, internal general medicine, still very much staying in a hospital environment. And as you get to the top, you're going into urban primary care, home care, community midwives. And you've got these, and eventually actually to the consumer. And what this particular report talked about was it not being enabled just by the miniaturization, but it depended on artificial intelligence, deep learning solutions going into these devices and working with them, because ultrasound needs to be made easier to use. And that's really the biggest barrier today. And you can divide that into two types of area you can work in. You can think about the sort of high income country setting, or more appropriate, maybe the hospital setting, where you have trained people who have a variety of skills and you want them all to perform very, very well at the task. And so the challenge is summarized in the figure here, that you want everybody to be much more clustered in the skilled high performance range. And that deals with workflow efficiency, QA. It needs to address things like ergonomics, because people scanning all the time, it's very bad for your wrist. The other new areas of application are coming in low and middle income country settings, more rural areas, and in primary care. And here's where you've got your new users. These are people who pick up the probe occasionally. They won't have had years of training. So you could think of them being on the range of unskilled to having some level of skill. And you want to support them, particularly in referral, point of care diagnosis. And all the solutions have to address low cost, whereas in the other area, you maybe don't need to worry so much about that. So in my research over the years, we've been looking at both these areas, and I was going to talk a little bit about some of the work we've been doing in both of those spaces, because the way we approach ultrasound image analysis is different. So why is ultrasound technically hard to do? It's really non-trivial. If you're trying to automate and get a robot or get a human to really perform ultrasound easily, it's different than a lot of medical imaging because there's a lot going on. If you are doing MRI and CT, your radiologists will often be just using their visual cortex. They will be reading. When you do ultrasound, you've got a lot of things going on. You particularly have to use your motor cortex because you're moving the probe, you're doing things on the screen, because you're now acquiring the data at the same time you're interpreting, and you're going backwards and forwards. And it's this complex hand-eye coordination that makes it hard. And that's, of course, is then, if we're going to think about how we're going to support people scanning and interpreting, we need to think about both of those things. So if we then look about it from an engineering, computer science perspective, you'll think of most of the medical image analysis focuses on the blue box here. It deals with quantification, detection analysis, maybe a bit of QA, quality assurance of the data. And that's really dealing with reading of data that's already been acquired. You don't worry about how it's acquired. But if you look at the whole ultrasound process, you've also got to think about the guidance part in ultrasound. You adjust and refine the probe position. You have to think about probe placement, which is placing it close to the object of interest. And the fact you've got this system is what makes ultrasound different. But for many years, you'd be working with data like this. This is ultrasound video. So all the computer has, or you have yourself to program, is data of this kind, and you've got to relate it to what's been going on by much more a human-machine interaction. And that's one of the reasons why ultrasound's always been challenging for computer vision researchers or people in medical image analysis, is because by the time you get to here, you've lost a lot of information about what's been going on. So what we've been doing is taking a step back and say, let's think more holistically about the whole process. And we can divide it into, if you recall, there was a highly skilled setting and the minimally trained setting. And if you look at the highly skilled setting, the person's moving the probe around, they're using all their knowledge. Oh, I'm not quite in the right position. Let me move the probe a bit more. So you have what we call a freehand scanning. You would then stop at interesting points, capture an image, and then the image analysis would take over and do the reading. That's the traditional way. And how the field has moved is now this standard plane capturing has been automated, and you're starting to see that appear. My spin-out company, for example, has been working in that space. So that means in the space of a highly skilled setting, there are examples now where you've definitely got, particularly recently, deep learning-based solutions can support people in that environment. How we've approached the other area in the minimally trained setting is to train people to sweep and count. So you sweep for so many seconds in straight line. And the way you do it is you have these very simplified protocols. So there's the T-shaped, and then you do the 3 lines. You then scan the other direction. You go back, you've actually turned the probe around, and you have the sweep, the smiley sweep of step 5. And so you have a structured scanning protocol that you can train people to do. And then if you put all those together, you've essentially done a coarse scanning over the whole of the anatomy, and then you translate the data across and translate that into a video image or video stream analysis problem to try and find out what you found from scans of that kind. So the difference here is you've now looking at a structured scanning protocol with sweeps, and that means you've got non-standard plane image and video analysis to deal with. And this is actually the problem that we've been working with a group in New Delhi, in FISTI, on. We've had a collaboration over the last 3 or 4 years. Started out in person, ended up on Zoom, like most people the last few years. And it's associated with a big study called the Garbini study, where they've added our protocol in. They are scanning pregnant women at multiple points of pregnancy. And on top of that, they do the protocol I've just shown you. And from that, we've looked at, for example, this optimization of the video acquisition, and looking also at how you can QA between UK and India sites. We've also looked at, we've developed from the T-sweep algorithm, sweep, a method of detecting breach, which is whether the head is up or down, which is really important to know when a mother might need to deliver the baby. It determines how you'll manage the delivery. And also looked at, for example, placenta segmentation, because it's very important to know the position of the placenta. If the placenta is low, that is ups the risk during delivery again, because the baby can't get past the placenta. And so we've developed a number of algorithms. Some of them are beginning to be published. Others are sort of work in progress. Here is just an example of this, looking at the placenta segmentation. It was with in some sense, a fairly conventional algorithm, a UNet, which had conditional random fields on top of that, and RNN in about it. And here it was, the blue here is showing the bladder, because it's good to be able to segment that. rather than segment the placenta on its own. But what was interesting here was less the algorithm. You've got an example where it worked, an example where it failed. But you could also introduce an element of explainability if you looked at the features that were represented for the different cases and project them into a TS&E embedding map. You could group together how successful segmentations were that were correlated with the shape of the placentas. And you found that the ones with the complex shape were the ones that are shown at the bottom, were the ones that were failed. So it's just an easy sort of way to start to be able to add some, not just report how well an algorithm works, but place it in the context that had some clinical meaning. A second example of one of these simplified protocol devices that we've developed is an algorithm from the image analysis put together with the probe that's shown on the slide here, which is a $850 wireless probe connected to just a standard consumer notebook. And the idea of this little tool that we call Tracer is to estimate gestational age. That's how many weeks pregnant a mother is. And there's a list here of why clinically this is important. It's important to deliver for delivering effective pregnancy care, to look at monitoring fetal growth, to make these timely decisions depending on how many weeks pregnant a mother is. And it's also used to determine low birth weight. But if the normal ways of estimating gestational estimation are by having an expert find what they call a biometry plane, and then fitting an ellipse or fitting a line, and then based on those geometric parameters, you would look up how many weeks pregnant a mother is. But most of these solutions previously are really aimed at not at specific points in pregnancy, which are aimed really at countries where you have screening programs and mothers would go at about 12 to 14 weeks or 20 weeks to have scans. And there are very few examples of being able to estimate gestational age reliably across pregnancy, particularly later on in pregnancy. So what we set out in this study, which was again associated with a large pregnancy cohort study, this time one in Sub-Saharan Africa, was to come up with a new way of being able to estimate gestational age across pregnancy. And this had, from an engineering or the computer science point of view, had two interesting elements. First of all, what we asked them to do was they were going to be measuring what's called a structure called the take a measurement called the transcerebellar diameter, which is known to be reliable for measuring across gestational age. And what we do is we ask our minimally trained clinicians to acquire a short head video. So they find the head, put the probe on, switch the device on. It requires 8 seconds of video, and they slowly move the probe around so that they're capturing various possible candidate planes. And then we developed a way to QA that video so that if it wasn't a good video, we could tell them to retake the video then and there. That's one of the beauties of ultrasound. It's very quick to retake a scan. So we developed this method. What it required technically was that you were working with limited data scenario, because we developed the solution from the study data, where we would have more tens of examples rather than thousands or millions of examples of the video. So we approached this using few-shot learning, which meant we also had a limited number of supervision examples. And the supervision in this case was where a clinician had found video clips that they considered to be high quality for measuring the head circumference and the TCD, the transcerebellar diameter. So you would have a small set here, and then you can develop an algorithm that was able to then take each frame and be able to give it a quality indicator. And you can see the sort of representation that we have on top. And the idea here was if you didn't see any white, you would be asked to retake the video. So it was quite simple. I'm not going to go through the technical details, but you're welcome to look it up. The second part of the solution was to be able to do a measurement. Now, in my lab, we have lots of data from high-end machines, we had very little data from the low-end ultrasound machine. So my team came up with a way of matching high-end with low-end so that you could use the high-end measurement to guide taking a measurement on the low end by a pairing technique. And the sort of accuracy you could get, again, this is sort of a nice idea here, was to use this, what they call the dual adversarial calibration method. You could end up estimating on the low cost data with a mean absolute error in millimeters of 2.5 millimeters and 1.65 millimeters, which is okay. It's whether you'd want to introduce it in practice. This is something that we're now looking at because it isn't accurate enough to a few days, but that doesn't mean to say from a clinical decision point of view, it isn't accurate enough to make certain clinical decisions in these environments. And I was just going to show you, just because I work in interdisciplinary research, I'm going to show you now just a little video that was made by the team in Kenya to get their views on this little device.
Prematurity is the #1 cause of death in newborns. It's therefore really important to have accurate data.
In Kilifi County, we're working in a rural area. Gestational age is primarily based on the last menstrual period that the mother provides to the nurse. For many mothers, it's either forgotten, or they didn't write it down, or they can't write it down.
Acer is a little ultrasound device, and we combine that with a tablet, and within that there is software that aims to make it much simpler for a non-expert who doesn't normally use ultrasound devices, for them to be able to scan and make decisions.
The device is very important because it is a very simple to use tool. You need your probe and your tablet.
Unapata uko katika ile kazi ngumu na ujauzito umeanza, so unapata pale huwa unajitafutia maradhi mwenyewe, na ningependa pia kujua mwezi wangu wa ujauzito ndio nianzie kujipanga.
I think the experience of the woman's pregnancy will change. She will be more aware of what's going on. She will have fewer surprises along the way. Knowing gestational age alone may not go far, but if that knowledge then causes the healthcare workers to intervene, refer the mother if she needs a referral, give the steroids if she needs steroids, deliver the mother if she needs delivery. If those actions follow from the knowledge of gestational age, then I think we will cause a big change in the outcomes of pregnancies.
So that, I show that video because it has nothing to do with the image analysis, but it shows when you start to work in these consortiums, they can get very excited about how they can think of the consequences of now being able to use, in this case, ultrasound-based measurement. You have a connection with the patient. The patient can see the fetus for the first time, and they can have a different conversation as well with the families. Be nice if it was to do with our research and our analysis as well, but that is an enabler here. So what I'm going to now talk about is some work we've been doing for the high-income country setting, which is really aimed at thinking about the workflow efficiency QA, and it's addressing really to understand this issue of why ultrasound is so hard. So I'll go back to this slide, and as I mentioned before, the ultrasound is a really complex process, and I was really, because what we were working with image analysis, I was trying to think of how could we really try and make a bit more of a transformational approach that could really try and understand more why ultrasound's hard and how do we define the assistive technologies. And it followed a number of sort of connecting talks I attended and talking with clinicians. Is, for example, clinicians, one of the experts that I was working with was saying that if they were shown a video, they could tell who had scanned it, who had actually scanned the patient. And you say, well, how would you know that? They say it's because of the way the video moves. And if it's one person who's a trainee, I'm not always confident making a decision from viewing. And in another part of our conversation, I was trying to get them to explain to me why ultrasound's hard. And they were saying things like, well, it's because you have to train people to look here and look there and look there. And I was like, well, how do you know they're looking there? And they'll say, well, because they are. And at the same time, I attended a talk that was all about using eye tracking. And I thought, why am I assuming that the clinicians can tell me where they look? Why can't we put an eye tracker on the system and actually measure where they will look? And then I started thinking more about that. And I was like, well, what we should do really is not just take the ultrasound video, but we should be thinking this as a system a whole and measure everything. And so rather than go from the video now and thinking about, particularly if you want to get into understand this red box, the key then was that you went out and measured it. It's not a new idea. It's been around for a long, long time. But if you can't measure something, you don't actually have an idea how you can improve it. So what we did was we instrumented the human now, in the sense I wanted to try and measure as many of the perceptions as possible. So you can use an eye tracker, you can look at vision, you can look at where people look. You can put a motion sensor on the ultrasound probe to understand how they move the probe. And you can use a microphone and ask them to speak aloud about things that they're doing. And so we go from having a diagnostic scan to now having a multimodal representation of what's going on for the whole scan. And so this allows us to think about ultrasound in a very, very different way. So we set up the instrumentation, looks like this. I'm not sure that the movie's working, but you capture the video, the little green dot is a gaze, and I think it might work if I press it. Let me see if it does. And you record the motion, and then also from the screen, you've got all the information about what was pressed when, to be able to also capture more about the sequence of tasks, for example. And so this has allowed us, we've now scanned, I think it's about over 500 real world scans. This is in a clinic in Oxford, their first, second or third trimester. And in fact, it's over 1,000 scans. And we have about over 300 from each type. And with this volume of data now, you can do some very simple things, and then maybe from a technical point of view, some more interesting technical things. You can just look at how long people spend on average on each task, for example. You can look at, see if eye tracking can classify the type of anatomy plane that someone was looking at. Those are sort of that's a little bit more from a sort of inquisitive study. You can look at where people look, which is what I mentioned earlier, on a standard plane. And you can also, the eye tracker allows you to measure pupil diameter. So you can also start to look at cognitive workload, which tells you how hard a task is. And so we've used this data to publish all that from an interdisciplinary point of view, all the way from clinical insight, all the way through to some look at some technical ideas that are too early to be introduced into a clinic, perhaps by a long way. So one that our clinicians was interested in was to check how often sonographers check safety measures, quite practical problems, a thing called the thermal index. And you have to go down and look at a particular position on the screen, and they are told to do this. And what you found from eye tracking analysis is that only in 4.2% of people bother checking things. But this maybe is not going to change the world type of surprise finding, but it was the first study that in the real world has looked at the scale and the completeness of following this. And it then led to in the clinical world, led to a discussion about the importance of safety. So it had the side effects there of raising the profile of safety indices. Looking at where sonographers look on a standard plane, these are the three standard planes you can see here, the schematics in the middle, examples of the image. And to define the plane, what's called the standard plane, where you've tilted the probe to see certain anatomical structures, you can use the eye tracker to be able to see if structures are actually looked at. And we compared this for second trimester and third trimester. Third trimester, the image quality has gone down a lot and certain structures are not as visible. So a question no one knew the answer to was, do sonographers still look in those locations, even though the structure might not be visible? And what was interesting was a change in eye tracking and gaze behavior, in the fact when you go to the third trimester and you can't see some of the internal structures, the reasoning of humans change, and you refer back to the midline a lot more, which is what's circled in red. And it was also through the largest study that was able to do this to date, to also give some numbers on how some of the smaller structures are not visible in the third trimester. Potentially, this is useful for suggesting when you train people how they should approach checking the planes. Cognitive workload is a very interesting one. Cognitive workload or mental load refers to the psychological effort of performing a specific task. If you've got an eye tracker, you can measure pupil diameter change, which is related to this. So we could, with our data, we could do the pupillometry in the wild, so as to speak, and measure task difficulty. And you just compute the change of the diameter by a very, very simple normalized metric. And in a small study, this was 14 sonographers, they'd taken 518 second trimester scans. We self-defined easy tasks, which were fetal biometry, 3D mode and maternal uterine artery, which our clinicians told us that they thought they were the easy task. And then the difficult tasks they would see, which means trainees find it harder to master, fine-tuning, looking at the abdomen, femur, head and spine. Taking those different groups of tasks, we could then compute the TEPR, and we actually could confirm that those were we could separate into difficult and easy, and also that people with more experience seem to find the harder tasks easier as well. And a final example of what we've been doing with deep learning with all these volumes of data is that you can annotate it with semi-supervised methods to take the large video scans and then partition it down into what anatomy was looked at when. And from that, you can then form things, what's shown here is a transition graph telling you the scanning patterns and what anatomies are looked at in what order and how you transition between them, and look at differences between individual sonographers or people who have more experience versus those that do not. And this paper we published was really describing the whole tool set to do that, and just some early examples of differences that you could pick out between people with years of experience of scanning and the people that were not. The next thing I'm going to talk about then is from just all the work there that I've talked about for multimodal has been very much sort of trying to describe, understand sonography through using a multimodal data set. The remainder that I'm going to be talking about is how we've also used that data to develop some assistive technologies. And we do that by thinking about combining different combinations. So video and gaze, if you have a video and gaze model, you can ask the question, can a computer predict where a sonographer should look? If you've got the video and probe model, you can ask the question, can a computer predict where a sonographer should move the probe next? And if you've got video and audio, you can ask the question, can a computer describe an ultrasound image or a video clip as well as a sonographer? And each of those questions we've looked at with this data set. I won't be talking much about the video and audio today, but I thought I would show you the results, the type of approach we've taken for the other approach, the other two examples of task. So the reason to do this is sort of fundamental to this whole multimodal project, and is shown here, is that you'd normally use all the ultrasound data, you'd have this video stream. But if you look at what a human does, is that little green dot there is where they're looking. And that's telling you the focus of attention. So if you can now give that information to a computer, it's a real strong constraint on what's important in these very challenging images that normal algorithms might find hard. So we use those two to be able to develop prediction algorithms. We've looked at this with a variety of models. Some of them are examples of architectures that originated in computer vision, and we've also developed some of our own. We've looked at how you can do gaze and saliency prediction for first trimester and also second trimester data, and also published work that's looked at the difference between spatial-based models and spatial temporal-based models. And the sort of thing that you end up with is illustrated just for what one of the models here is, which is a saliency model. Here you're looking at the head, and the two hotspots you're seeing there are the salient areas that, of course, the saliency model is telling you on average where a human would look on this particular frame. And what the green cross is where the person was actually looking at that time. Now, unless you've got special eyesight, you can't look at 2 points at the same time, which is why it flips between them. But as you can see, the green cross is approximately where the saliency points is. So what we're doing that, so the sort of status I would say at the high level is, based on the work we've done to date, we can predict where a sonographer may look quite well. And the current open question, which is the one that we're looking at now, is this useful for video guidance in practice? And we have a project now that's seeing how we can use this sort of technology and figure out how it can be used to guide a trainee or someone who's not as experienced in scanning using these hotspots as a guide. And that's ongoing work at the current time. For ultrasound guidance, this is moving from quantification detection, particularly looking at this adjust, refine probe position. And so what we're doing here is we're using the probe motion with the video to start with. And we've looked at this from two perspectives. One approach would be to treat the human as a robot and generate an algorithm that, given the video and probe information, would tell you how many degrees you have to move rotate the probe to get into the correct plane. And we've developed that would be what I would call a control parameter prediction style method, which is fine, but humans are not robots and they don't always know how many degrees to move. So that's maybe not an ideal solution. The other approach, which we published last year at MICI, is a landmark retrieval-based method, which has been built with some data from an ultrasound simulator, where in the ultrasound simulator, we captured lots of data in a known coordinate system, and then you can do a lookup between the ultrasound image and the ultrasound image that you would then capture yourself, and the lookup is determined by indexing on an ultrasound descriptor that you've initially developed from the trained model of the simulator data. And when you capture the real image, you compute its features and figure out which image, it's an image to image which map through the retrieval technique, tells you where you were with respect to the object in that space. And so that's a really much more intuitively and natural way to guide someone, because if you have a model, you can show them where they are on the fetus. How you translate that to the clinic would be the subject of future work. As I say, it's more for training people at the moment. And this is just some results from that, which I think I'll probably just skip over. And our most recent work, sort of combining the two, is to try and really model, which is for the first time, this whole process of sort of gaze and probe hand-eye coordination model. And it's basically builds with a graph-based structure the relationship between an ultrasound image, a gaze point, and that from those two, you can then predict the movement going through that first triangle. And then if you've got the probe movement, you'd be able to generate the ultrasound image and also a gaze point. So if you think about the process as a whole, if you've got the data, that you can train from, you can try and build this connection between the image, the gaze point, and the probe, which I call, you know, it's now become you're modeling a human action rather than just one component of that. And the person who's done this, Quinn Hugh, has done a really nice job. She has this a graph sharing structure, which she calls multimodal guide net, which allows the prediction in the end of two things. You have a gaze trajectory prediction and you have a probe motion prediction. So it's essentially taking the best bits of the two previous types of single prediction tasks. You now make it predicting both of them. These are flipped with respect to what shows as output. So apologies for that. I realized that this morning. So what she's shown, though, if you compare using gaze and ultrasound with this new model of gaze probe and ultrasound in terms of the prediction error accuracy of where to look, you find that what's shown here in the dark red is the new algorithm, that its prediction error is significantly lower than the single task methods. And similarly, if what's shown in the top graph, the red is the new algorithm, and this is looking at the prediction accuracy of estimation. It has the best accuracy compared with using our previous model, which was just predicting based on probe information alone. And the final example I was going to show you is a little bit different. This is looking at using the audio and video data, and from the audio and video data, predicting gaze. So this is an idea that's been inspired by computer vision, audio-visual representation learning. What's interesting about the data we're using, which is spoken audio of the sonographer and the video, is that there's a very sparse correlation, because the sound we're talking about does not come from the visual source, which is what's been done in computer vision before. And we were partly interested in, or that my postdoc was interested in audio-visual representation. So he was interested in how good can you learn an audio-visual representation for ultrasound and video, and took this speech-guided visual localization task as being an interesting one to use, because we've got our gaze data. So we could see, if using audio and video, how well could you predict the gaze. It builds on some work that Jambo, the postdoc, had been working on self-supervised contrastive video speech representation. And what he's done with that is he has these three streams: an audio stream, a video stream, and from the audio you can derive text. So he ends up with 3 nets, and from that he builds his overall audio visual representation, and from that he then looks at the task of gaze prediction. Now, I'm hoping you can hear the audio. This is some output. You've got the real gaze, which is shown on the right, and then the algorithm is showing the audio guide.
Nose here, top lip, bottom lip there. You can see it? Oh yeah. Amazing lips there, it's like a cleft palate. So cleft lip, I should say, cleft palate at birth.
I think what's really remarkable is that generation on the left has been purely generated without knowledge. So actually, it's also showing the power of
two bows in the forearm. Two bows.
So what's going to end with now, I've shown you all the ultrasound work, is a little bit Alison's view of the world, but thinking about what's happening now and in the future. And the way I view it is for medical image analysis, we've got these 3 areas we care about. We care about the algorithms, we care about the data and annotation, and we care about the evaluation and translation. And of course, a lot of the focus in the field has been on algorithms. And so you can ask, is it all about innovation in the algorithms and methods that's going to take us forward? And there might be people nodding because they're computer scientists and go, yes, 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 it's all about the algorithm. Has to be all about the algorithm. I'm clearly not going to say that. Now, for me, there are very exciting areas. I've showed you multimodal analysis. It's a new way of thinking in medical imaging, things like self-supervision, some of you might be familiar with. These are areas where it is and can be all about the algorithm. But you always have to bear in mind that the closed world and clinical AI, this really matters. The closed world of algorithms today do not place those predictions in the context of what clinicians do. And that really, really matters. So I'm sorry, it can't all be about the algorithms. We have to go beyond that. So, no, sorry, I'm going the wrong way. So then you can say, then is the future, is it all about access to data and annotations? Again, a lot of people go, I need data, then I can solve problems. And it's not that straightforward because our field deals with regulation of use of data. And some people want that problem to go away, but I believe it's here to stay. And so what you need to do is, and you need to respect that, it's people's health data. So respect of data privacy, and for international sharing of data, this is one of the big challenges at the moment. How do we go about doing that? There are ways to do that. We're, for example, starting to work with federated learning as one of the techniques. And I think there's a lot of opportunities for being able to work on shared problems, but maybe it won't involve actually sharing the data. We also, this problem may be familiar, we do not understand how to factor data imbalance. You can't ask a hospital to give you balanced data. They will give you the data that represents the real world. So we need to get better at how we can deal with the fact data comes from different devices, sites, studies, and populations. This is an active area. It's very non-trivial to solve that. And then the one that, if we look at the data, is, do we need to do human annotations? 10 years from now, will we be doing any annotations? I think that's a really interesting question. I think a lot of people would rather we didn't have to, but those are the barriers. So then you go the other end and you go, okay, so there's lots of work in algorithms that we sort of know about, data annotation, evaluation and translation. Do we understand how to evaluate clinical AI? One of our problems is we use technical metrics too much, but that doesn't normally tell you how the success of an algorithm in the real world. And there are little discussions about this, but a lot of academic papers are focused too much on the technical metrics. So we have to do better at really thinking about, will my algorithm work in the clinic? Even if it works badly, how would it work if I took it to a clinic today? I think we need to ask that. And then interpretability, trustworthiness of a clinical AI algorithm, that is a very, very hot topic at the moment. But what does it really mean, and how interpretable does it need to be? And how do we come up with better ways to measuring that? That has meaning, not to ourselves as technically, but has meaning as well to our clinical collaborators who are going to use this technology. And then the final one on translation, what barriers are there to deployment and adoption? There's regulation of medical devices and clinical AI algorithms. Personally, I think this is progressing quite well, but it takes a long time to get an algorithm approved. And the algorithms being, if you need to update it, it's very, very costly. The clinical and public trust in clinical AI technology, I had that on my second slide. I think the public trust is developing, certainly in the UK, but that might not be true globally. The clinical trust, I think, is a harder one. They're the professionals who you're now asking to use your technology, and we need to work more in that space. And then there's the whole issue of ethics. Should you be able to take your own pictures, medical selfies? Should that be allowed? And the one that's really not addressed very much is changes in workforce skills. So we come up with great solutions. What will the doctors do? How will it change what they do? If you have assistive technology and the clinician is still in charge, that still means they need all the expertise to be able to decide that they have to take over. So there are some real issues that are in healthcare, but there are also issues that are for AI in general. and how you get humans and machines working together in harmony. And that to me is the really exciting part of the next 5 to 10 years. So just to summarize then, I think it has been a very exciting era for ultrasound, but it's still only scratching the surface because there's always wonderful things to do next. And it's been enabled by deep learning, this large capture, low-cost sensors. So it's really those three capabilities. We're starting to get deeper understanding of clinical sonography, which I call sonography data science. And we're starting to get these assistive technologies that can guide a sonographer as they scan, not just about help them in reading. And it's no longer about quantification, but it's really embracing a lot of the ideas coming from artificial intelligence. So there's also people in the audience who don't work in medical imaging, and you'd like to come and join us all. You're most welcome to come and join us all and solve some problems together as well. So thank you very much.
Hello. Yeah, thank you, Dr. Alison, for the talk. Now we'll take some questions from the audience. Yes. Maybe hold on.
Yeah, I think you better have the microphone.
Hello, I'm audible. Ma'am, I want to know, in medical imaging, or we talk about in the broader realm of natural sciences, there's a concept of uncertainty estimation. Like we deal with aleatoric uncertainty and epistemic uncertainty. So what happens in ultrasound imaging and like in ultrasound imaging, and when we are using this deep neural networks, so can you shed some light on like how we would be quantifying epistemic uncertainty or aleatoric uncertainty for a particular network or particular inferencing of an algorithm, or like in general in the entire, if you're conducting a study, like how we would be quantifying it in that realm? Like how will calculating epistemic uncertainty for an ultrasound imaging kind of a scenario?
Well, I think you can, with any problem, you'd have to define it through the task you were looking at, right? So you can define it, and the paper's published. We've published in that space. Deep learning, I'm not sure that's maybe the best way to do it. We've done it with Bayesian-based methods, but you would be challenging with certain test data sets to test how the algorithm responded. That's how people do that. And maybe that's a high-level version of your answering, but being able to understand that would be addressing one of the important components of trust in algorithms. There aren't, but people today wouldn't publish algorithms that reported both. Whether they should in the future, it would be interesting to see if that would actually help clinicians or not, or it will be an overload.
Yeah.
You mentioned non-experts, using non-experts for doing that. Maybe you scan in a structured way across, and then maybe you have to model the whole thing or something. Is there much? Have you done much work on it, or is it more going on in that front?
So we're actually looking at that now. One of my PhD students is starting to do the multiple scans. What's challenging in the fetus is the fetus isn't always in the same position. So you're going to factor that in, that it could be that way, it could be lateral, it could be head up, head down. But for me, the next wave is doing that, is really understanding you've essentially just done a sparse mat, essentially. What can you determine? I think that's your question. But we're approaching it more than thinking about using graph-based methods to do that. If anybody's got any other ideas about how you do it, come and chat with me. But it is about having that spatial awareness. But it is a very interesting one. If you go, for me, I often go back and talk to clinicians about what they do. They would be using the first scan, they sort of recalculate in their brain where things are, and then they will do a prediction based on the second one. So they build a representation from the scans. So that's another way about thinking about solving. But I think there is a way, that is a nice way of going forward in thinking about what the sonographers will do, because they will place a probe on and then they mentally build this picture, whether it's of the fetus, whether it's of a liver, whether it was a heart. And that's the bit that you don't, that memory of what you found as you go along and building the model, which I think you're referring to, is a very interesting area. But there isn't much data out there to be able to model problems like that, because you don't naturally capture ultrasound data that way. The data set we've got, you could start to do that. Possibly, and I wouldn't answer on behalf of my clinical colleagues. They might shake their head in despair and say that wouldn't be possible. But yeah, I would say that.
Those are the things that they look for in India, because the number of experts is huge. You want to get into the local area.
Yeah, you can do that. I know when I spoke to them originally in Oxford, they were very against doing that, which is why we took the approach of get the person who's there scanning simply. So it'll be interesting to see how that type of approach evolves as well.
Yeah. So I'm PK. I'm a faculty here. Thank you for that talk. It's wonderful to see ideas actually translating into technology and being used. I'm sure you feel very satisfied. I'm going to connect to your convocation talk on Saturday and something what you talked here. So there actually you said your interest in this clinical itself was an accidental meeting with some clinicians in 2 days workshop that you attended, and taking it from there. So just to give you context, we are actually about 40 people in this room from a summer school called Computational Social Science. And the students in that summer school, are half of them are computer science engineering students, and half of them are economics, social work, psychology. That's some of us are in this room. So my question to you is, given that you've done this successfully, what would you suggest somebody getting into trying this, so to say, going in multiple disciplines, to keep a watch for 3 things that you would suggest we do and 3 things that you suggest we should avoid?
3?
Let's do 5 then.
Oh wow! I'll be quiet then. So you mean in terms of between disciplines?
Yeah. So for example, there's a student in where's Maitreyi? Yeah. So she's actually studying psychology, clinical psychology, right? And where is Ajinkya? Ajinkya is studying computer science in Hyderabad. So we would like them to do something together, right? Or we are inspiring them to do something together. So now what should they look for?
Well, what I would do is you have to immerse yourself in the other field. So you have to go and hang out and get out of it's all about getting out of your comfort zone and going and spending time in another field. You will not understand what they're talking about to start with, but you just listen. It's all about listening. Listening, observing, picking up. And you don't do that once, you do that 3 times. Does that count as 2 of my things?
No, that's only 1 now.
And what you find is, in fact, for my students going to work with the sonographers, they go once and it's like, oh my goodness, what's happened? I don't know what's going on. The second time, because they're conditioned on the first time, some of the noise goes away. And it's the third time they start to really understand what's going on. So it's really important not to take 2 people both out of their comfort zones and get them to meet. That's great as a start, but then each of them needs to go and spend time just immersed, because you will then get appreciation for what's going on. But I think also you get an appreciation for where the opportunities might be. And then you can start to ask questions like, why are you doing this? And why are you doing that? And you, of course, have got to be comfortable in asking what you might think are dumb questions, because there isn't such thing as a dumb question. That's all about education. So that's the next thing, is actually to ask questions and then reflect. And what I find is it's a personal thing, but if the idea stays around with me as it being an exciting idea about 4 weeks down the line, it's probably worth going back and having another conversation and learning more reading about things and then taking it from there. But the fundamental thing is immersion. So what I've done, I haven't just worked in fetal. For me, I just thought it'd be really interesting because I'd read about fetal ultrasound, but I hadn't found anything in the literature that I thought was interesting enough for me to work on. But I was invited to go to a meeting and just spend time with these, very eminent obstetricians. And the one thing I remember was they couldn't agree on how to define gestational age. And I was like, how can all these people from all around the world not agree on a basic definition of what is sorry, not gestational age, what is a healthy pregnancy? And then just listening and hearing the different perspectives, you understand that they explained why it was hard to actually define it. And if you haven't spent time that, you won't find that as a sentence in a paper. To really understand what are the true challenges, you have to spend time. And I've worked in cardiology. I used to go to cardiology meetings every 3 or 4 years. I wasn't presenting, it was just to go and hear what they were excited about. Because when you get two people together, they will generally try and find a common problem that they think can be solved. And it's not often that is the right problem to work on. It's because everyone's being nice and they're saying, I think, computer scientists, I think you can solve this problem for me. And then maybe the other way it goes, I think that might be something. And then you get this artificial problem that's actually not really what needs to be solved. So you go through that quickly and then you start over your coffee or whatever, you'll be saying, well, what about this idea? Would that work? That's when you start to collaborate.
Okay, smaller one. Next one is I think if I remember correctly, you said in 1990s this meeting happened, 1990s or 2000.
Yeah.
If you were to go 25 years before and ask you to restart what you did, what would you do differently?
What would I do differently when?
25 years before.
I wouldn't do anything differently. I never look back. I don't think I would do anything, but it is I don't actually view things that way. Could I have done things differently? Probably not.
Okay.
I think you just find a path.
Okay, thank you.
Sorry if I didn't answer that in the way you.
No, that's okay. That itself is a great answer. No, don't look for anything. Yeah, thanks.
Right, let me see if I can find them. Let's hope they're nice questions. Is it this one?
Hello, ma'am.
Hi.
Actually, I have a question. Is there any way to pre-predict the fetal alignment or anything so that it can help the unskilled person? So like this is any EC2 scan, fetal position, things like that. Is there any way to tell the person before?
Well, I think that the simplest example of that is the breech problem, is the head up or down, which is very clinically important. It's to do with delivery. So from that point of view, if that's what you mean by pose or position, you would find the head position. Is that what you meant?
Yeah, like upside down, like we can find the head in the down, like that way. Like some alignment information will help an unskilled person. That's why I asked.
Yes.
Or backward, like the kid is kind of roll position, then it is difficult. Things like that. Some prior information regarding the position of the fetus can help. No,
that's correct, and that's the scanning protocol that the clinicians have come up with allows you to determine that. You have to scan in certain directions. The easiest one is to just scan straight up, but that's not actually the most accurate way to determine position, because the fetus can be slightly off as well, off position.
Okay, okay, that is kind of remember I didn't get, like, is there when we train a new person who don't know anything about the things, is there any way, like, are we giving the information prior? That's what I'm asking. How he is learning, or some methods are helping him to understand.
Work is that you wouldn't know anything. You would just be focusing on scanning slowly in certain patterns, if that's
okay. Okay. Okay.
Okay. Hello, ma'am. So your talk was great. And so I come from a economics development studies background. And so what I've noticed is that AI systems actually just digitization at large in lower middle income countries tend to perpetuate socioeconomic inequity. And so certain people tend to get left behind. And in healthcare access, especially in a country like India, say, where in certain areas there will always be a lack of experts. Reliance on AI by people who aren't experts can also increase a number of undiagnosed cases going forward, or like certain people may not be taken into account, certain abnormalities. So I'm wondering if the research that happens in this field sort of takes that holistic approach while going forward, and if so, yeah, how do you do it?
So the little video I showed, which was the study from this study in, it's being led in Kenya, we let them define the applications, because that then addresses your point. It's no good me coming along and saying, you know, I can build a device that does this, go and test it. So what we ask them to do is to identify the scenarios in which you might use these capabilities. And what we're doing with them now, the breach detection is one that they say will be useful, and that the people who would be scanning to determine breach would then be able to fit into the clinical workflow, which is what the point you're addressing. What they found just in a clinical research study is that the women they recruit who come back multiple times, they do come back, and they come back because they care about the health of the fetus. They wouldn't normally have ultrasound scans, and because they're given an ultrasound scan, it also allows the study to be able to check for other things. So ultrasound is a really powerful camera that it's more than the diagnosis. It allows acceptance of pregnancy as well, and the treatment of women as well can also be helped by this. So maybe that's partly addressing what you're saying. I think, yeah, I think it's that the cases we're looking at would be trying to help with the aspects that I can understand would be a concern otherwise.
Okay, so I have a quick question, especially in context with the eye studies, with the eye tracker. So usually when you were looking at the movement of the clinician's eyes while he was doing the sonography, were we looking at normal pregnancies? Because in case there were abnormal ones, the movements would be different. And obviously that would impact the algorithm which will determine the eye movements. And secondly is in context with the socio-cultural variables. So in the sense that the clinicians in India, so there are certain laws pertaining to being sensitive about, about sex selections and things like that. So wouldn't the eye movements for that be very, very different than what it would be in, certain countries which do not have these kind of legislations?
Well, I think on your first point is the work I showed was not dealing with diagnosis. It was finding the planes prior to then doing the clinical decisions. So based on that, we wouldn't care what was wrong. Sounds bad, but you wouldn't. That isn't part of what the technology is taking you for you to then be able to do that. In the actual training data, I don't think we did have any where they were doing that as well. But you're correct; they might be looking at other places as well. But I'm really about getting just the device being able to capture the image. What happens after that isn't an area I work. Your issue of using ultrasound in pregnancy in India, I'm not going to go near. It's I know it's a massive, massive issue. And my collaborators are very conscious of that as well. And I think there is decisions need to be happen in your own country about what you might change or what you won't in terms of being able to use ultrasound more widely in pregnancy by different operators. But it would be fantastic if that conversation could start again for the benefit of all the women who might benefit from having more scans.
So first of all, Professor, thanks for the wonderful talk. Like it just blew my mind. You just covered it maybe in 45 minutes, but it's a work of the lifetime. And you had to collaborate with so many people, and these are very sophisticated, deep tech solutions. And you were also successful in commercializing it, because without commercialization, we lose technology. So what is your advice for commercializing deep tech solutions?
Well, it's not all about me, of course. I've never added it up. I've probably worked with hundreds of people for the work you've shown that, and in the company, I'm not driving it. I'm a consultant, so I'm not going to take full credit for that. But if you want to make things happen, you do work in teams. You have to get the right people around you with a common vision, and then you try and make it happen. And so that's what makes it happen. But from going from your academic group through to the how it's commercialized, people are motivated by a common wish to have an impact.
Professor, so when we use a multimodal approach for fetal ultrasound data, apart from the probe, there is something to do with the audio, something to do with the eye. So how are these protocols standardized across different countries? Is there any standard? So even in ultrasound, if there is a standard, the speech, how should it be standardized from different healthcare settings?
So in terms of gaze, it is partly standardized because if a lot of countries follow international standards on, it's about finding a plane and you check which structures are in the plane. So if that's standard and you expect to see a stomach bubble, umbilical vein, see a spine, see the ribs, people should be looking at those. So from that point of view, there are international standards of anatomy. So that helps from that perspective, the gaze. On the audio, I didn't show you some of our other work, but the audio, ours is just for free text we've used. So there, what you're generating is a possible text description associated with that image. If you wanted to do anything that was more to do with diagnosis, you would have to get people to speak in a certain way because you'd be trying to standardize on that, but we haven't looked at that problem. I think it's too hard. Sonography is enough about focusing on what you do without asking people to now speak aloud and explain what they're doing. But it would be interesting to see if you could do that too. Of course, doing it for one language and then generalizing it to other languages to make it global would be another interesting extra dimension, but that's where the natural language people can come in and tell us how to do that bit.
Thank you, ma'am. One more question. So again, how much ultrasound is useful in operation room setting?
Sorry, how much
in interventional care?
Yeah.
How much is ultrasound currently used, or what is the scope?
Well, it depends what you define as interventional, but it's used for things like cancer, prostate cancer. If you count that as a biopsy as an intervention, it will be used for looking at heads. The problem ultrasound doesn't go through bone and the skull, so you have to drill a hole, or you have to look under by the circle of Willis. And what have I missed out? There must be some other examples as well. Liver. But yeah, ultrasound is being used, and some of the types of techniques I've used could possibly extend over, but interventional is much more exploratory. It's less standard on, find this plane. So the fact we've got structure in what we tell people to do, you're moving into freehand ultrasound and being able to guide someone to do freehand ultrasound. We're not there yet. We're hopefully getting there, but I wouldn't put a timeline on that, particularly as this is being recorded. But come back to Bournemouth.
Thank you.
Thank you, Dr. Alison, for answering all the questions from the students. Now I request Dr. PJN to give a souvenir from IIIT.
Thank you so much. Thank you very much. It's very kind. Thank you. And thank you for the wonderful questions as well. It's been a very nice discussion.